Hello, everyone, and welcome to Managing Side Effects webinar. I'm sorry for the technical difficulties. My name is Antoinette Powells. I'm the Research and Outreach Manager at the LifeRaft Group, and I would like to introduce our presenter for today, Dr. Weiss. She will take the floor and talk about managing side effects.
So thanks so much for the opportunity to speak with you all today. I hope this lecture is helpful to you, and I hope we can get some of your questions answered. So our topic today, managing side effects of gastrointestinal stromal tumor therapies. So as many of us know, the primary treatment for GIST is a class of drug therapies known as tyrosine kinase inhibitors. So tyrosine kinases sit on the surface of the cell. Essentially, they're like the motor for the cell to tell it to grow and divide. And essentially what happens in GIST is that these particular proteins are mutated. And so they're overactive, and they're essentially telling the cell to divide without stopping. And that's why we end up with tumors. So the idea with these treatments or tyrosine kinase inhibitors is they're blocking that abnormal protein and hopefully getting the cell to stop dividing and hopefully to lead to cell death and decrease of the tumor. So the common tyrosine kinase inhibitors used in the treatment of GIST, we all know imatinib or Gleevec, which is often the first-line therapy, Sutent or sunitinib, Stivarga, otherwise known as regorafenib, Qinlock or apritinib, and then Ayvakit or avapritinib. And we're going to be talking about the first four in terms of side effects, just because they're the most common that we see in clinical practice. Okay, so just to quickly review the objectives of this talk. So we're going to review the common side effects of these drugs that are observed in clinical practice that I see and others. We're going to point out the side effects that are unique to the certain therapies. We're going to discuss how to manage these side effects at home. And then, of course, when to call clinic. So without a doubt, the first thing usually a doctor is going to sit down and discuss when it comes to side effects of these drugs are the GI side effects, specifically diarrhea, nausea, sometimes vomiting, and stomach discomfort. Diarrhea certainly happens quite a bit. I would say the vast majority of patients are able to manage, but for some, it's very difficult and can really impact day-to-day life. And so it's important to know how to manage it. So most of the advice that we would give to patients with diarrhea is similar to the advice we would give anybody with diarrhea, which is to eat smaller meals, try blander foods that are lower in fiber. The brat diet is often something we recommend, which is bananas, rice, applesauce or apples, and toast. We typically recommend avoiding raw fruit and vegetables, caffeine, which can act as a laxative in some. Spicy foods and dairy products can also affect the GI system and make diarrhea worse. Over the counter, you can buy Imodium. I'm sure your doctor would talk to you about that. You take 2 tablets after the first bowel movement and then 1 tablet after each subsequent bowel movement. I always tell patients if you're having more than 3 episodes and they're large bowel movements and you're uncomfortable, you should talk to your MD just to make sure. There's a drug we'll often prescribe after we've maxed out the Imodium called Lamodal. And this is a powerful drug that really slows down the GI system and can help diarrhea. The problem is it can cause constipation, so we want to be very careful to take it as prescribed because it can certainly cause some problems if not taken appropriately. With regard to nausea and vomiting, so I typically recommend that patients take their dose with food. You can always talk to your MD. I typically just give a prescription for a nausea medicine when my patients first start the drug. So Compazine or Zofran are often prescribed. And I typically tell patients to take it 30 minutes prior to the GIST therapy, imatinib, Stivarga, whatever it is. And that usually can help, especially to allow patients to eat after. And it also can be helpful to take the dose at night. So if you are going to experience some nausea, hopefully you're sleeping through it. And then with regard to stomach discomfort, the diet changes we talked about above certainly can be helpful. And just over-the-counter simethicone or Gas-X, if a patient's having kind of just upset stomach, a lot of extra gas production, can be very helpful. Some other gastrointestinal side effects, appetite loss certainly can happen, mouth sores, altered taste or what we call mouthfeel disturbance, which can manifest as hypersensitivity to certain foods, For some folks, it's super hot foods, super cold foods, spicy foods, or acidic foods. When it comes to appetite loss, it can be a little bit tricky because it could be related to the drug itself, or secondary to other side effects that interfere with a patient eating. And the best advice we can give, which is probably pretty obvious, of course, is eat what you find appetizing. Don't worry about taking 3 big meals a day, like a lunch, breakfast, dinner, but small meals throughout the day is totally okay. And just doing the best you can to supplement nutrients and making sure you're getting a well-balanced diet. And if you feel like you need a dietitian to talk through that, it's important to do that and talk to your doctor about that. For mouth sores, these are less common with imatinib or Gleevec, and I would say more common with Qinlock, Stivarga, Sutent. Really important to just have really good oral hygiene, which you probably are already doing, but making sure to really brush teeth and utilize mouthwash after eating any meal. If it's very severe, lidocaine or magic mouthwash can be prescribed by your physician. And if it's just a few spots, you can consider doing Oragel, which is just over the counter as like a spot treatment on specific areas that are bothersome. When it comes to altered taste or that mouthfeel disturbance, people pretty quickly determine which are the foods that trigger them, and as best we can to avoid those triggering foods. Some people complain of like a metallic type taste in the mouth. So avoiding using like metal utensils or drinking from those insulated cups could be helpful. Additionally, magic mouthwash, even saltwater rinses or alcohol-free mouthwashes, all of these are potentially helpful for some. I've had patients tell me that sucking on ice cubes can help it a bit. And then utilizing a soft toothbrush so you're just not disturbing the gum in that whole area can also be beneficial. So we're going to talk next about some of the skin and hair side effects with these drugs. Hair loss and hair color change can happen. Again, less common with imatinib, but certainly something we see with Qinlock and Stivarga. Not necessarily that a patient loses all their hair as they would with, classic chemotherapy, but something to be aware of. Skin rashes can occur. Often they're itchy and they kind of look like the picture on top. They're a classic, what we call maculopapular rash, which is kind of splotchy. Can happen on the chest, the abdomen, on the arms sometimes. Sometimes it's very small and we can give some creams, which we'll talk about, to manage them. But certainly if it's, affecting the whole body and it comes on suddenly, if you're having other symptoms in association with it, you should certainly talk to your doctor. Dry skin is something patients note a lot. And then just in general, kind of skin discoloration, sometimes in the nails, sometimes in the hands. And then very important to talk about the hand-foot skin reaction or hand-foot syndrome, sometimes called palmar-plantar erythrodysesthesia. So this can be very troublesome and very bothersome to patients. So it's important, if you're beginning to experience these symptoms, reach out to your doctor sooner rather than later, just so we can hopefully take care of the problem before it's a bigger issue. And it's sort of less difficult manifestation. Sometimes it's just numbness and kind of sensitivity to touch, maybe painless swelling. That can progress to more painful swelling and difficulty with sort of fine motor skills and just in general having pain. And then in the worst case scenario, you can kind of see the picture here. You can have skin peeling, ulceration of the skin, and then pretty severe pain preventing daily activities, in this case, walking. So it's important to be aware of this. Hopefully we can manage the side effect before it gets that bad. So, for mild hand-foot syndrome, urea-containing creams, moisturizing creams can be helpful. There's a couple over the counter, or your doctor can prescribe it. We typically recommend that patients, use it on their hands and feet, and if they could put on like gloves or socks to prevent it from just evaporating, that's useful. For a rash that's not, too involved, a steroid cream can be helpful. For severe pain related to the hand-foot syndrome, topical lidocaine can be prescribed. And then, certainly if it's bothersome enough, we definitely need to consider dose interruption, so holding the drug for some amount of time, and perhaps restarting with a decreased dose, which would lessen the risk of that occurring again. Okay, so fluid retention and swelling is something that's commonly seen more with imatinib versus the other types of tyrosine kinase inhibitors. Bilateral lower extremity edema and periorbital edema, which is swelling kind of around the eyelids, are two of the most common complaints patients have. When it comes to just mild swelling in the legs or in the eyes, if it doesn't bother you, we can just keep an eye on it. If it is bothersome, we typically recommend first supportive measurements, really taking care to manage your salt intake, which a lot of folks just don't realize. Even if you don't add salt to your food, a lot of processed foods will have more salt than we even realize. But things like leg elevation, compression stockings are also useful in that scenario. Truly, if it's bothersome, your doctor can prescribe a diuretic like Lasix, which will help your kidneys basically take off that extra fluid so that you urinate it or pee it out. There's been some evidence out there that topical steroids can be used to help with specifically the swelling around the eye. Don't think it's a surefire thing for everybody, but certainly worth a try in some. And then antihistamines like Claritin or Zyrtec also have been beneficial for patients. So reasons to call your doc. So if you've got severe leg or facial edema that kind of comes on suddenly, definitely reach out to your doctor. If you're noting unilateral leg swelling or just one leg is swelling over the other, I would typically see that both legs would be equally swollen. So if one's worse than the other, maybe we need to be thinking about something else, and it's worthwhile to reach out to your doc. If your doctor prescribes you some sort of diuretic like Lasix, if you're noticing severe dizziness, fatigue, headaches, maybe your dose is too high and needs to be reduced, because those can all be signs of dehydration. So just important to be in touch with your doctor about any of those symptoms. Ocular or eye-related side effects. Again, this is most commonly seen with Gleevec. And this little chart here is taken from the pharmaceutical company that makes this drug, Novartis. We talked already about the periorbital edema, and here's a picture of it, just that kind of swelling around the eyes, which for some is most commonly in the morning and then gets better throughout the day. Epiphoria or excess tearing, I think probably is related to the periorbital edema. I think that can be one of the issues patients have if there is swelling in that area. And then it's possible but unlikely to happen something like blepharoconjunctivitis. That's essentially when you have swelling of the inner eyelid, as well as the conjunctiva covering the eye. Can be very bothersome and painful. So certainly, if it's bothering you, reach out to your doctor. Something like ptosis when the eyelid droops, or abnormal vision. These are possible side effects, but certainly if they're happening, reach out to your doctor. Okay, so we're going to talk next about fatigue and memory impairment, which is something I hear commonly from patients as a complaint. And there have actually been studies that have shown that fatigue, insomnia, and specifically verbal memory loss, so word finding issues and difficulty remembering what someone verbally said to you, are seen more frequently on patients that are on these types of drugs. Sometimes fatigue and memory impairment, or just brain fog, as some will refer to it, can be linked to anemia or something else going on in the blood work. So we shouldn't just blame it on the drug, and make sure we look for other etiologies. And additionally, if a patient's dealing with fatigue or insomnia, either related to medication or for other reasons, certainly that can cause a decline in cognitive function. So it's just important that we're addressing all potential causes. So in terms of management, the non-pharmacologic things that we can do not using medicine, it's recommended that patients maintain physical activity, typically 3 to 5 hours a week in 10 to 15-minute sessions, just to keep yourself moving and keep yourself active. Sleep hygiene, doing the things to prepare yourself for sleep, and to avoid distractions and that sort of thing. Massages, acupuncture, taking care to make sure your nutrition is adequate. These are all things that can really make a big difference in patients that are dealing with fatigue. And then some pharmacologic options for patients that have severe fatigue and can't function well throughout the day. Stimulants I will often prescribe. So Ritalin, a lot of folks know, is a drug used in children or adults with ADHD. But in lower doses is actually a really good drug to use to help patients just get that kind of up and go, that kick to be more awake and up during the day as opposed to fatigue. I have many patients that find that very helpful. And then, patients that are having difficulty with insomnia, sleep aid can always be discussed with your doctor. I'm a big fan of a drug called Lunesta over like Ambien or some of the others on the market. But certainly important to make sure that you're having good sleep, because it does affect so much. Okay, next side effect we'll review is the cardiovascular side effects, most notably hypertension. We see this most commonly with Sutent and Stivarga, less commonly with imatinib, but certainly can occur. We tell patients the goal blood pressure should be less than 140/90. Especially patients starting Sutent or Stivarga, I ask them if they can have a blood pressure cuff at home to really get one and take note of their blood pressure a couple of time points during the day. Also a good idea if you can to bring it to your doctor's office and just make sure it's accurate, compare it to the ones in the office. Sometimes we need to add drugs to patients' regimen. Sometimes they're already on blood pressure drugs and we'll need to change doses or change the drugs entirely. Losartan and Coreg or carvedilol are drugs I'll often use. But especially if you're on the drug, you're noting a lot of headaches, dizziness, confusion. Definitely talk to your medical doctor. I think if you're not keeping an eye on the blood pressure, might be an important thing to do, because that's something that can easily be managed and cause a lot of trouble if it's not well managed. Okay, so in terms of some of the other side effects, these are laboratory side effects that you may not feel or know, but are important that your doctor is keeping an eye on, which is why at least when you begin therapy with any of these drugs, hopefully you're getting lab checks relatively frequently. Electrolyte abnormalities can happen. For example, with Gleevec or imatinib, low phosphorus is often seen, and we need to replete patients for that. Hepatotoxicity or liver toxicity. It's less common with these drugs, but certainly there's been reports of patients having a rise in their liver function when some of these drugs, specifically imatinib, are mixed with acetaminophen or Tylenol. So just important to be aware of that. But this is something that your doctor should be keeping an eye on and watching every so often. And then decreased blood counts can happen with this drug as well. Especially if a patient already has, for example, anemia. Could this drug theoretically make it worse? It's possible. So it's important, to make sure, again, if a patient's having fatigue, we should probably be checking the hemoglobin and making sure that that's okay. But important to be aware of that and something that your doctor is looking out for. So these are some other side effects that didn't really fit into one good category, but muscle cramping, we see that pretty commonly with imatinib and often in the beginning of dosing. There isn't a whole lot of great fixes for this, but certainly there's been actually some data on L-carnitine supplementation has been shown to decrease episodes, but certainly something you want to talk to your doctor about before you would start it, just to make sure it doesn't interact with anything you're already taking. Cleaning water is also helpful for some. In some cases, if you have a need for calcium or magnesium supplementation, that could help. And there is, to note, there is some risk of bleeding on these drugs, especially if a patient is starting the drug and they have a large tumor, as that tumor is hopefully being destroyed by the drug and is responding to drug, you could have bleeding from that. So certainly, if you're on a blood thinner for other reasons, just important thing to be aware of and discuss with your doctor. For a lot of patients, I shouldn't say a lot, but for several of my patients, specifically on Sutent, they notice voice changes. Specifically, hoarseness is something I hear quite a bit from patients, and there is some data to suggest that there's just fluid buildup or edema in the same way that there can be fluid buildup in the legs and around the eyes. The same thing can happen in the larynx or in the throat, which can cause voice change. If it's very severe, like any of these symptoms or side effects, stopping the drug, holding it, and seeing if that's the cause might be worthwhile. Thyroid abnormalities is also important. Any of these drugs can affect the thyroid. And the thyroid, as we know, it's a super important organ that affects many, many things in the body, including metabolism and temperature management and all sorts of things. So if the thyroid is affected, and with these drugs, it's usually hypoactive or hypothyroidism. So it's not working as it should. Patients can experience cold intolerance, certainly fatigue, dry skin, swelling of the face or in other areas. So, important to think about this and make sure your doctor's, keeping an eye on it, especially if any of these symptoms are present. So that's actually that's all that I have in terms of side effects. I kind of want to give folks a chance to ask questions, or we can expound on any of these topics. I'm happy to do so.
Thank you, Mia, Dr. Weiss. And we do have some questions that patients have asked before the webinar. One is, what is the best way to control rashes and muscle cramps?
So the muscle cramps, as we just talked about, these are some, as listed here. Here's some things that can be tried. It certainly can be very difficult for patients. I recognize that. There isn't a quick fix though. I've had patients make sure that, they increase their activity, they find it's better. Some patients note the opposite, they increase the activity, they find that it's worse. So it is sort of finding what works best for you. And then the other question you asked about was rashes. Here we go. I would say, especially, if it's the hands, the feet, like we talked about, these urea containing creams are great. Patients find a lot of benefit from them. Steroid creams for itchy rashes certainly is an option as well. And again, if it's very bothersome, you may want to talk to your doctor about holding the drug, and it all kind of depends on how severe it is, how bothersome it is.
Great, thank you. And another patient asked, I have severe muscle cramps, rigidity, freezing, minor muscle cramps since diagnosis progressing as time goes on. I went to a neurologist and he wants me to start on a Parkinson medicine, carbidopa, levodopa. Of course, I do not have Parkinson's. He thinks it might be a dystonic reaction because of the cancer. Have you heard of this?
So I think I would ask the patient back if it's something that they note with taking the drug, like it happens after taking the drug, or it's just a constant issue all the way through. Because, certainly I think there's a lot we don't fully understand about how these drugs work. For example, there's probably some immune reaction that takes place when these drugs take effect, that the extent of which we just don't fully know, but that could be the reason patients note some, shivering or shaking or fever-like symptoms, or even muscle cramping. If it's sort of a long-standing issue and it's truly started after the drug, I would, if I were the physician in that case, I would try holding the drug and see if that really made the difference, and then have a careful conversation about restarting it in the future.
All right. And then one more that was off live was my eyes have been sick looking, jaundice since I started Gleevec, frequent eye bleeds, which are severe. Have other people had this?
So what was the first part?
My eyes have been sick looking, jaundice.
Got it. Okay. So certainly, jaundice is typically associated with liver dysfunction, specifically in elevation in what's called the bilirubin. As we talked about, there can be some liver toxicity associated with these drugs. So probably the first thing we want to do is make sure that that's not what's going on. But in general, jaundice is not a common side effect of these drugs. Now, the eye bleeding, I assume we're talking something more along the lines of this blepharoconjunctivitis, which is when, again, you have that sort of redness at the eyelid, and then at the conjunctiva, which is the covering of the eye itself. So that, that can look pretty bloody, even though it's just pretty severe inflammation. And if it's bothersome, certainly something worthwhile to talk to the doctor about, and even seeing a ophthalmologist would probably be a good idea too.
Thank you. And then for the live questions,
Sure.
she asked, how do you feel about splitting the dose to lower side effects and help liver and kidney health? There's three questions to this. How about reducing imatinib to 300? Is it still effective? And how can I tell that I am having a good response to imatinib? Like lots of side effects means extra sensitive.
Yeah. So the first part of that question, I absolutely, if it means that the patient tolerates the dose better, split it up. I think that is fine. And I've spoken, excuse me, to my pharmacists about this extensively, and they're in agreement. That's absolutely okay to do. I think you specifically asked about liver and kidney function. I don't know that dosing it that way will make that difference, but in terms of, like, say a patient's having diarrhea or nausea, that can help. And then the second part of that question was with regard to
Reducing imatinib.
reducing the dose. Yeah. So
Yeah.
I honestly, it really depends on the situation. There's, as you know, a lot of reasons why folks are on Gleevec. You got people taking it after a surgery. You got people taking it before surgery, hoping to shrink the tumor before surgery. And then you have folks taking it in the metastatic setting, when they have metastatic disease. And I think in each scenario, it's worth having a discussion. So for example, again, it really depends, but if you had a patient that was taking it neoadjuvantly or before surgery, and they're really not tolerating it, it may be just time to go to surgery, depending on, how the patient is doing and how the tumor has responded thus far. Let's say the patient is, metastatic, and they noted that they're feeling better on a 200 or 300 milligram dose. I think it's worthwhile to try. And in metastatic disease, if it's working, and the patient is tolerating it at a lower dose, you don't know until you try, but I've certainly seen it work at lower doses. And if it means the patient feels better on it, awesome.
Thank you. He asked, is Tylenol issue with sunitinib? I guess, is it an issue with sunitinib, Tylenol?
Yeah, so some folks do get some liver irritation with the drug. Hopefully on your first set of labs, you can see if there's been any irritation to the liver from the drug alone. I probably, just to be safe, I tell patients if you can avoid it, when we're first starting out, just to see how your body responds. But in general, a dose here and there, if you need it for a headache or whatever it is, should be okay. Absolutely should be okay.
Okay. And then should her doctor be testing for phosphorus? It's not typically in her blood workup.
I typically do, but other doctors may feel differently about that, but that is my practice.
And then
just because I've seen it quite a bit.
Yeah. And then do you recommend testing blood plasma concentration levels if a patient is having severe reactions to imatinib? And how could she get a test like this?
So I don't know that that's an easy test to obtain. I don't think that's a standard test in most hospitals. So probably not. But you get sort of the same answer if you hold the drug and see improvement in those symptoms. It may just be telling us that your body cannot handle that full dose, which can be the case sometimes. And a dose reduction is appropriate in those cases. But as far as I know, at least standardly, I don't believe we can do that test easily.
Okay. If I have iron deficiency causing focus problems and fatigue, what form should I get tested for? Is there a home remedy to help until or if he needs supplementation?
Yeah, so if a patient has iron deficiency anemia prior to taking the medicine, it's a good idea for the primary care doctor or the hematologist oncologist to do the additional testing to confirm it, and make sure the workup is done to explain why it's happening. But certainly it's probably a good idea regardless to just manage that before you would start the drug. And there's several different ways to supplement iron. That's a whole topic, but certainly it's important.
And then how about the manufacturer of the drug? Does it make a difference in the side effects?
Yeah, it's a really good question. And I have absolutely had patients tell me that they respond better to the generic form. And I don't know why, because they're biosimilars and they really should behave the same way, but clearly there's something about it. that's different. I've seen that in a couple patients now. And, if I'm able to, from an insurance and a cost perspective, I'm able to switch it. If a patient's not tolerating, I will. But why exactly that is, honestly, I don't know. But if I can find a way for the patient to tolerate it well, I'm glad.
And then excess phlegm, is this common? I'm constantly clearing my throat.
Yeah, I've seen it in a couple patients too. It's hard to know if it has to do with, a bit of dehydration because you're sort of getting more concentrated sputum in a way. So one thing I would say is just make sure you're hydrating really well. That can be helpful. And also if you had a recent virus, it could be related to like something entirely different.
All right. And then he said his wife is experiencing a severe runny nose after surgery on a reduced dosage of imatinib, 200 milligrams.
Well, there's an increased runny nose. I don't, I wouldn't say it's impossible, but especially at a lower dose, that's interesting. And it's hard too, right? Because especially right now, all these new variants of COVID are going around and other viruses that we may not be detecting on the usual tests. And we know that a lot of the viruses we pick up these days, they can linger in terms of symptoms. So it's hard to say it's definitely related. But certain, you can try Flonase over the counter or prescribed by your doc, is often helpful for people that have excessive rhinorrhea or runny nose. That's an easy thing to at least try. It wouldn't hurt.
And then any treatments for skin discoloration?
Not that I know of. It's certainly, a bothersome thing for sure. I get that. As far as I know, though, I've not found anything that's been particularly helpful in that regard.
And then what are your thoughts about using prednisone to help your body tolerate imatinib after dropping imatinib dose due to severe reaction to it?
I guess I would ask what the specific reaction is. Steroids, it's certainly not standard to give steroids for the majority of side effects related to these drugs. And steroids are no joke. We can use them in short bursts, but we certainly don't want to use them long term because they come with side effects. So I would guess, I would wonder if, the severity of the side effects and what side effects they are.
Is there a reason for dizziness? I occasionally have it and don't know what it is related to.
Yeah. So could be related to a couple things. Without knowing your history and kind of your specifics, it's hard to know for sure, but we got to be making sure that you're hydrated appropriately, that your blood pressure is not affected by the medicine, that you're not anemic because of the medicine, a whole bunch of things it could be related to, but not something, especially if it's severe, not something to just be like, it's just the drug, but certainly have your doctor look into it further.
And then do you switch to the other TKIs in case of intolerance to Gleevec?
I am one of those that I will do whatever it takes to keep a patient, especially in the metastatic setting, to keep a patient on Gleevec. So I'll play around with dose quite a bit and make sure, obviously that we're not losing control of the disease. That's most important. But yeah, if we really cannot find a way to tolerate it, yes, I will switch. There's some data switching because typically we'll do imatinib, then Sutent, and then regorafenib or Stivarga. But there's actually some data from a tolerability standpoint. Sometimes we can switch from imatinib right to ripretinib or Kinlock, and folks find that a little bit easier to tolerate in some cases. So in short, yes.
And then going back to the question about prednisone, patient asked his side effect was a whole body rash, itchiness, and then his blood work indicated internal organ issues. Prednisone was used to get his body back to normal. Now he's trying prednisone taper and will be increasing imatinib again.
Yeah, I mean, certainly if it helped the effects, I mean, like I was saying before, there's probably some sort of immune reaction that's taking place that we don't have a good grasp on. So could it have been some sort of immune effect of the drug and prednisone kind of balance that or decrease that, yeah. You know, if one can come off that taper and maintain, you know, good activity or good tolerability, I should say, on the drug, that's fine. I mean, that works.
All right. And then we'll take a few more questions as we're wrapping up here. What's the lowest effective dose of Gleevec if 400 is not tolerated? Is it reasonable to take 100 to 200? Setting is post-surgical, no tumor.
Yeah. In those situations, you know, it depends how, in this particular anyway, depends how high risk the tumor was. Sometimes people sit in that sort of moderate risk, and their doctors still recommend that they go on adjuvant, which is fine. But I think less is known about the effectiveness in the adjuvant setting. I think we can clearly see, or at least I can see, in the metastatic setting when we use lower doses, and I typically will not go under 200. Some patients do maintain disease stability at the very least on that. But you know, if the side effects are severe for a patient, really affecting day to day, and perhaps the risk of recurrence is not that high, you may want to have a discussion about the risk benefits of continuing it. If the risk is very high, it may very well be worthwhile to try a lower dose. It's, you know, better than doing nothing. But I just make sure we're doing all supportive measures so that we can tolerate.
And then is skin flushing and hot skin common? My face and ears turn red and hot. Is it hormones or imatinib?
So I wonder, it kind of similar to another question we asked, does it happen like right after taking the drug? Does it happen all day? You know, I've heard patients say that with imatinib kind of in close proximity to taking the drug. Again, why it happens or what sort of reaction, clearly, you know, as we know with these drugs, they hit that tyrosine kinase inhibitor, that's the target, but there are these off-target effects. It's not a perfect target. And that's why we see the side effects. And although the majority of which we do understand, there's certainly some that that are not 100% clear. But like anything else, you know, if there could be another cause, it should be looked into before we blame the drug.
Thank you, Dr. Weiss. And then we'll do one more. And if anyone has any other questions, you can always ask afterwards. You can reach out to our team and we will answer for you. So she said she has a severe meibomian gland dysfunction from imatinib. She tried Elux treatment. Eyes still bother her a lot.
Say that, spell it again for me.
ILUX treatment.
And what was the type of?
Severe MEIBOMIAN gland dysfunction.
Okay. Huh.
And her eyes still bother her, and she uses heat masks every day and eye drops 2 times a day. Is there any other recommendations?
I would say at that level of discomfort, definitely seek advice in, you know, I would say have your doctor be a part of the conversation with an ophthalmologist, because certainly there are things to do. You should not be uncomfortable like that, but you know, especially if you know, eye drops and all that management hasn't been helpful, see if we can escalate the care to get some additional advice from an expert specifically with eyes.
Thank you, Dr. Weiss.
Yeah, appreciate it. Thank you all.
So that's the questions that we can answer here. Just remember that the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. We thank everyone for attending today, and thank you, Dr. Weiss, for presenting. Yeah, and have a great day, everyone.
Thanks, everybody. Appreciate the opportunity. Take care.